Hello, everybody, and welcome to the remote lecture for this week. I am going to start with the laboratory values case study that is in your notes right before the cancer lecture began. If you haven't yet had a chance to read through this, I'd recommend just pausing the video now and reading through the case and then starting it back up. All right, so as we go through the case study, I'm just going to walk this through as if I'm doing the chart review myself and just kind of verbalize what I'm thinking as I go so you can kind of hear the process. For right now, given where we are in this course, I am going to largely ignore how these lab values relate to the specific diagnosis, just because we haven't talked about them yet. I'm going to really focus this chart review on lab values and what they mean for patient readiness for PT. How might the clinical representation match the clinical lab values? What additional information might I need to know given this patient's lab values? What kind of questions would be good to ask? That sort of thing. All right, so I'm going to start at the top as if I am reading this and kind of processing this in real time. For your information, when I do a chart review or consider a case, I'm always kind of in the back of my mind keeping track of all of the cardiovascular risk factors. The reason for that is it gives you a larger clinical picture of your patient to appreciate their overall health. It also, individuals with more cardiovascular risk factors typically have a more complicated hospital stay. They're more frequently dealing with medical complications. It also might relate to the way the medical team treats the patient. A patient with more cardiovascular risk factors might be treated more aggressively, whereas someone with fewer cardiovascular risk factors, they might take a more conservative approach, kind of a wait and see approach, given the background of their health history. So that's just something I keep in mind as I go through. All right, so our patient's name is Mrs. Sujin Chen. She is 58 years old, which is our first cardiovascular risk factor, because once you're above the age of 50, that is a cardiovascular risk factor. She's female, so she has doesn't have the sex increased cardiovascular risk factor. Her body weight is 184 pounds and her height is 64 inches, giving her a BMI of 31.6. So once you get above 30, that is kind of the clinical threshold for obesity. So from this level, she is clinically obese, which is my second cardiovascular risk factor. I'm going to read how she presented her illness, kind of keeping in mind which symptoms was she presenting with so that I can relate this back to what her clinical lab values show. Patient presents to the emergency department feeling short of breath. Okay, that's a symptom for the past 2 days. Patient is currently unable to ambulate. Okay, and that might qualify for a PT symptom. Patient is currently unable to ambulate and has been feeling lethargic for 3 days. She has been experiencing muscle cramping in her lower leg, but currently there is none present, so that has gotten better. She's been using 2 liters of oxygen. I'm just going to identify this as an intervention she's on, so I'm just going to use a different color. She's been using 2 liters of oxygen via nasal cannula. She needs some oxygen support. And just a few days ago, her Lasix dose was doubled to help manage her congestive heart failure symptoms. I'm going to hit on Lasix when we talk about the meds. She reports her quality of life has significantly declined in the last month, and she now requires 24-hour assistance. All right, let's look at her current medications and think about how it relates to possible pathology. Okay, so she's on Lasix. If you're less familiar with Lasix, this is a diuretic, which they mentioned in the present illness summary that they were upping this dose of a Lasix, so she's on a higher dose of a diuretic. Diuretic's kind of getting rid of liquid out of the body. I'm just kind of thinking this through as I read it, painting the clinical picture. An ACE inhibitor. An ACE inhibitor is a drug that blocks the actions of the renin-angiotensin system. Okay, so an ACE inhibitor, if you're blocking angiotensin system, this would be antihypertensive drug. It also, and you guys will get this more probably in pharm, has a bit of diuresis, so it can kind of help that maybe like a little plus diuresis. That's good too. Ooh, insulin. Why would a patient be on insulin? Let's read on. Medical history. Aha! She has insulin dependent diabetes. That would explain why she is on insulin. So she is taking exogenous insulin to help manage her blood glucose levels. She has a past medical history of hypertension. So this fits in with the clinical picture that we see because she's on an antihypertensive med and she's in stage 3 chronic kidney disease. We'll talk a lot more about this, but we did learn in our lab values lecture that patients who have, difficulties in their filtering system, their kidney, they might have poor activity tolerance. All right, let's look at her vitals. All right, first looking at blood pressure. Her blood pressure is 102/58. So I'm always going to be relating this to my norms. So I would expect blood pressure to be less than 120/80, but that seems a bit below 120/80. So this looks like we have a low BP. Her heart rate is 110. Okay, normal heart rate. Do you guys all have this sort of internalized? Normal heart rate is 60 to 100 beats per minute. So she is sitting at rest at 110. So she has a high heart rate. And her respiratory rate is 32. All right, normal respiratory rate is 12 to 20 breaths per minute. 32 is quite high. So she also has a high respiratory rate. So breathing a lot of very frequent breathing. All right, so she is diagnosed, her medical diagnosis is acute on chronic exacerbation of congestive heart failure. Let's look first at her CBC, her complete blood count. All right, hemoglobin and hematocrit are both low, right? For female, 12 is normal for hemoglobin, 37 is normal for hematocrit. So we see reductions here. Now, how bad is this? Right off the cuff, you could look at it and say she's just a notch below normal. Do you remember the cutoff, that blood transfusion cutoff was 8 and 24? She's a far ways from that. So that always is sort of my floor, not to say you can't treat someone below that, but I kind of keep this in mind as my floor for H&H, because sometimes it's hard to know where you are in the range if it's just sort of less than normal. Okay, so we have lower hemoglobin hematocrit. What does that mean for our patient? I think we hit this in both the lectures. So for patients like this, you'd expect maybe poor endurance. Some people would describe that as fatigue and lethargy in class. We talked about increased shortness of breath, which already, if we look back, we can see her respiratory rate was high. She was complaining of reduced endurance, difficulty walking. This can cause an increased heart rate, which we're seeing above as well. She is tachycardic right now. So we have a patient who's just below normal. Some possible presentations of that kind of fit with some of her clinical picture. What would be a good question we could ask nursing to investigate how well she's tolerating this? We want to be able to get as much information as quickly as possible. If we asked, is her hemoglobin affecting her patient, the nurse is going to give you a funny look. So what question gets at this issue of what we're seeing here, poor endurance, shortness of breath, high heart rate, that can give us a lot of information. A really good question, if you're wondering how well someone's going to tolerate activity based on any lab value, is have you gotten this patient up yet? That's they go to the bathroom, they're getting to the chair. Nursing gets patients up a lot. If the answer is no, then you might be the first one to get them up. And then you're going to want to document their response to activity. If they say yes, your follow-up question is, how did she tolerate activity? And depending on which lab value you're asking this about, you might really point that question specifically. How was her cardiac rhythms when you got her up, for example, for something else. Here you might ask if was she very short of breath during activity? Did her oxygen saturations hold during activity? Something like that. All right, let's look at white blood cells. So white blood cells are 6 out of a 5 to 10. Obviously, that's times 10 to the third per microliter. So we're in the normal range. Is that good, bad? It kind of rules out an infection, or at least no evidence of an infection here. They're not so low that I'm worried about exposing this patient who couldn't fight off an infection. It's just normal. All right, her platelet count is 145. Again, that's times 10 to the third per microliter, easily within the normal range. So based on her platelets, I don't see any obvious bleeding risk here, right? There's nothing to draw my attention to this value in any way. All right, let's look at her basic metabolic panel. All right, her first one is sodium. Her sodium is 118, and the norm is 134 to 142. This is pretty low, right? So we have low sodium. All right, what does that mean to our patient? Sodium is the primary determinant of extracellular fluid volume. So when sodium is out of the normal range, the big thing I'm thinking about that one is what organ is affected by big changes in fluid volume, and that's the brain. So I'm wondering about potential cognitive impairments. So I'm not going to see that anymore. All I have is this number. Perhaps in a nurse's note, I might see some reference to their cognitive status that could help me. This would be a really good one to touch base with nursing before you go in. Is she following commands? And that gives you a lot of information into her cognitive status, and you can obviously ask follow-up, more specific questions if you need. All right, potassium, 2.1, quite low. All right, so potassium is low. And this really ties back into the meds. If we kind of scroll back up here, she's on that big diuretic. When your patients are on diuretics, they can often lose potassium. It's a common side effect. And we see that here, that her potassium is low, and that actually kind of fits with one of the drugs that she is on. What is the concern with low potassium? All right, so potassium is important for electrical membrane potentials. The one I'm really worried about is her heart. So is there any cardiac issues with this patient? It's kind of running through my head. What can I do? I can check any EKG reports that are in the medical record. I can look for reported findings, if there's any documentation of arrhythmias. Depending on what I find, this might be questions that I need to ask nursing. Is the patient on telemetry? Has nursing observed any abnormal cardiac rhythms? Is the medical team planning a potassium supplement? Because with a low potassium, it can be an easy-ish fix, depending on the source, to just supplement with potassium. Okay, so these are all things that kind of coming in and kind of keeping in mind. Chloride is low, which makes sense because it's with its buddy, sodium. All right, calcium. Calcium is in the normal range. So nothing new to add to my plate to think about for calcium. Glucose is 188 mgs per deciliter. All right, so normal glucose is 70 to 100. This is pretty high, but I will keep in mind that the norm that might be on this chart could be lower than what is appropriate for this patient. She's under a bit of stress. She's in the hospital. She's getting meds and tests. And I know that for hospitalized patients, the norm is 140 to 180. So she's still above that. if I go back, I said I wouldn't do diagnosis, but I think this one you guys are familiar enough with. She is a diabetic as well. So this is high. Maybe they're kind of probably maybe playing with insulin to try to figure out new dosing, considering that she's under stress. Okay, so in general, what does this mean? It's higher than it should be. Clinically, what does that mean? Perhaps she might have a little more fatigue than a patient with more normal glucose. This, because it's higher than the expected range even for hospitalized patients, you might want to follow up with nursing. In clinical experience, this isn't sky high. I mean, it's outside of the normal range by textbook definitions, but so a question might not be, a question you could ask about this is there a concern regarding her glucose levels? That kind of opens the door to saying, fill me in if the team is concerned, and doesn't really reveal if you're like overly concerned or not. Just, is there a concern regarding her glucose levels? Kind of opens that dialogue so you can hear what the medical team is thinking. All right, her, let's look at her kidney test. So both serum creatinine and BUN are elevated. So this does relate back to she has stage 3 chronic kidney disease, but all by itself, if you just want to really focus on what does this lab value mean to me, this may affect activity tolerance, right? When these numbers are up, when GFR when GFR is reduced, it can affect patients' activity tolerance. So again, kind of learning how she's tolerated previous activity could be relevant here again. So that kind of ties back into when you ask the nurses, if they'd gotten her up and how she tolerated activity. All right, so she has a number of laboratory values that are outside of the normal range. Let's go back up to her summary of present illness and see how these fit in. I'm just going to erase some of my red writing so that doesn't look too messy when I get through this. Okay, so she presented with shortness of breath. Have we found anything in here that really helped relate to shortness of breath? Perhaps her H&H levels? Those were pretty low, and she's not carrying enough oxygen. She might be struggling to deliver that. Unable to ambulate and feeling lethargic. So if we put these together, probably having difficulty with activity, obviously unable to ambulate. In a different class, you're probably going to ask a lot of questions about musculoskeletal, what's going on with the ambulation. Let's stick with activity tolerance in terms of ambulation, just considering what class we're in. All right, if we go through, she actually has a number of laboratory values that might have been contributing to her really low level of energy and activity tolerance. One, again, could be H&H. Not enough oxygen is going to affect activity tolerance. Lethargic could be related to the sodium, because sodium affects cognitive status. Feeling really groggy and tired can be related to cognitive status. She has glucose levels that are outside of the normal range. That one seems a little bit of a stretch, but I'll keep it on here for completeness, because as glucose goes up, your activity tolerance can go down. Her BUN and creatinine levels are both high, suggesting a further failing of her kidney function, which could be related to feeling lethargic. Muscle cramping in lower legs. If I'd look back on the list of her lab values and what's outside of the normal range, this could be related to the potassium, because if potassium's outside of the normal range, that can affect cells with excitability, like muscles, and that might have been part of her muscle cramping. I highlighted 2 liters of oxygen because this will become an important piece going forward. We obviously haven't talked about oxygen support yet, but knowing baseline oxygen support can give you a lot of information depending on how much oxygen she's now needing for support. So that's just an important piece that you're collecting as you go through to know what their normal support level is compared to what they're on now. So as we go through this chart, we see a lot of the symptoms do fit her clinical lab data. The medications that she's on make sense with the diagnoses that she has. The vitals are outside of the normal range, but nothing is scary levels. Blood pressure being low, if when you would move this patient out of bed, if they couldn't maintain pressures, if they would drop further, that could be problematic. The respiratory rate, once it starts getting higher, they might not have a lot more to go if they need to take up more oxygen, but this isn't sky high. Hemoglobin hematocrit, I might expect that impacting PT, but it's not low enough that I wouldn't treat. The basic metabolic panel gives me a couple things that could interrupt my ability to treat. If her sodium has really affected her cognitive status, that might be an impairment to therapy. The impact of potassium on her heart could be a breaker for therapy. This might be the case that you just need to wait until she gets the potassium supplement before you treat. If she's had no reports of cardiac issues, she's on telemetry, you could proceed with monitoring, but with caution. And then her glucose levels are not so high that I wouldn't treat. And her kidney, she's already been diagnosed with kidney disease. I kind of expect them to be elevated. This isn't kind of probably a new finding for her if you looked at trends over time. So once I get my questions answered around sodium and potassium and how well she has done with activity and what kind of monitoring they're currently doing, this would be a patient that would be appropriate to be seen for physical therapy. Again, based on the answers to some of those questions. All right, I hope you found it helpful to kind of walk through a chart review together. We'll do some more as we go through the semester, and we'll move back into Cancer.